Hello, and welcome to another episode of No Notes, where the conversation is always a perfect 10 out of 10. This podcast is powered by Elios Health, the most used and most loved AI platform in behavioral healthcare, equipping over 100 organizations and over 10,000 providers with powerful automation tools that streamline documentation, simplify compliance, surface deep care insights, and provide clinical outcomes. I'm your host, Denny Morrison, today, and I'm thrilled to be joined by my old friend, Mike Johnson, Senior Managing Director of Behavioral Health at CARF. And we're going to talk about CARF and CARF accreditation and accreditation in general a little bit, and how AI is viewed by an accrediting body like CARF. So welcome, Mike, and thanks for being here today.
Thanks, Denny. It's a pleasure to be here with you.
Well, first of all, tell us a little bit about what you do for a living. I've been wondering about this for years, but
well, it is sort of a ambiguous sort of position, I suppose, and a title such as Senior Managing Director, right? My role is predominantly to be like the executive lead for behavioral health for CARF. So CARF is an accrediting organization that actually accredits in multiple domains in healthcare, not just in behavioral health. So we accredit in medical rehabilitation, for instance, and in IDDD service areas, and child and youth services, so child welfare and aging services, so long-term care facilities, dementia daycare, that sort of thing, and OTPs as well as behavioral health. And so behavioral health is the largest area that CARF does accredit in. And so my responsibility is to kind of be the interface between us as an organization and the field, to be able to be kind of the individual that is the target for all of the information to ensure that we are relevant in the behavioral health market. I'm the one that's responsible for writing all the standards in the behavioral health manual. So in order to be able to do that effectively, I have to play a role in the marketplace in terms of interacting with payers, regulators, at different states and at the federal level, and also interacting with customers a great deal and getting their feedback about what's working, what's not working. So that's primarily what my responsibilities are. I have obviously other duties as assigned as everyone else does in every organization, but for the most part, that's a description of kind of what I'm doing in a day-to-day, month-to-month basis for the organization. And I've been here for going on 12 years now in this role. So time flies.
Time does fly. Now, you have a technology background, though. You were a CIO for a while, right?
Well, I was not a CIO. I worked for one of the companies that became NetSmart Technologies. So I was a clinical consultant with that organization. So I did EMR implementations with organizations in really the earliest version of EHR implementations that existed. I did that for about 7 years. So it was, of course, it's funny when you say I have a technology background, I think like, yeah, but the technology was way different back in like the late 90s, early 2000s. I can't say that I'm a technology person nearly as confidently as I was 20 years ago.
I know that feeling. I tell people I'm a psychologist, but I feel like I have to give them all kinds of caveats and warnings. It's like, do not look at me for therapy because I'm so far out of the loop on that these days. But but we are going to talk about technology a little bit today. And when I think about AI, I think what we get a lot of times at Elios are clients and prospects who start thinking about this, and they wonder what an organization like CARF thinks of the use of these technologies in terms of their documentation requirements and those kind of things. And so, first of all, before we get into kind of CARF's perspective on this, what from your perspective, and you've probably heard some of this before, what are you hearing about the biggest misconceptions about AI in the behavioral health space? Are you hearing anything about it?
I don't know that I'm hearing anything more than you would hear sort of globally about AI anyway, right? I think that it's funny to me when you hear the term AI, what that means to people is going to be filtered through whatever their varieties of experience might be. And they aren't really thinking about it in terms of what the practical application is, perhaps in their day to day. It's what am I reading in the news? What did I see in movies? Is it all coming to get us? And I think that just as an individual, I mean, my exposure as a person in my day to day life is starting to obviously see where AI is playing a role in what it is that we're doing. But it hasn't really, changed significantly, much in my life. I will admit that I have been kind of testing some, Chat GPT and some of the Gemini tools around some of our writing, and trying to see if I can't improve the quality of some of our writing examples and things like that in our standards manual. But it hasn't been very much yet, because I think that there's still a long way to go before it can have that kind of utility. I know both from some exposure to Elios and some competitor software, kind of what the role is that is being played in behavioral health right now, and really around the note writing aspects and trying to help organizations to be able to ensure that the progress notes that are being written are an accurate reflection of the service that was delivered. I'm hopeful that there will be sort of more tools that are going to, come down the road in the behavioral health space, really around kind of decision support for diagnosis, around helping around treatment planning, and not missing things that are that come up in the assessment. I don't probably want to get out too far ahead of you, but one of the things that I think about a lot is when we do a biopsychosocial assessment in the behavioral health space, there's an awful lot of information that's collected, and there's a lot of conversation that happens between the clinician and the person that's being served. And I think it's really challenging for a lot of clinicians to be able to gather all that information, to be able to enter much of that information into the appropriate templates, and then be able to clinically evaluate the meaning of all of that information to be able to come together with a cogent clinical formulation. And then what are the primary problems that the individual is presenting, and what are things that are within the scope or the domain of that particular organization, and what isn't. I think that individual clinicians struggle with that. And I'm really hopeful that starts to be the direction too, that it's more than just sort of passively listening to a session and being able to identify what were the main foci of that particular session. I think that's valuable. I think that's meaningful, and it delivers real day-to-day value to the individual clinician and to the organization. And I don't think there's any question that that's true. But I think that that there's more help that AI promises in the future, that I think is going to be way more meaningful for individuals. And I think that it will allow for a much more robust workforce. We have an awful lot of workforce challenges in the behavioral health space. There are only ever going to be so many psychologists like yourself, so many licensed clinicians. We need more allied health professionals, paraprofessionals, peers that are going to be involved in a lot of the routine care. And I think that AI can be really helpful in ensuring that there's adequate communication, throughout that ecosystem, and to make sure that the focus that the clinician, that the person needs is continuing to be focused on the right things, right? So that's way more probably than you were asking for, but I just got on a roll there for a second.
Well, that's okay. That's why we do these. But I tell you, I agree with you. I think that's where we're seeing, we're right at the beginning of this whole technology. And I think you're right. It's going to start bleeding into things like biopsychosocial and, psychiatric evals and, med checks. And I think we'll see lots of value added propositions coming up as we go forward. And I think, to me, what's kind of interesting about where we are today is I've said this many times, that this technology is one of the first technologies I've seen since I've been in this business that really is directed at helping clinicians do their jobs better, easier, faster. And so that's a good thing. On the flip side of that, that means clinicians have to learn how to use AI in a helpful and structured fashion, and to use purpose-built large language models for that purpose. But I think we're just at the beginning of it. I mean, I think we really are going to see kind of this nice blend of clinical knowledge and advice, but not decisions coming from AIs in the form of like Amanda, if you could just do a biopsychosocial and I could just talk to you through that, and then the AI takes care of filling in the boxes and summarizing and doing all the structural stuff. We're not far from that. We're doing a lot of that with progress notes now. So I don't think that's too far in the future, frankly. But I agree with you. I think that's where it's going to go. But it's going to mean a sea change for clinicians. So, kind of back to the point from the perspective of CARF, do you guys kind of have a pony in this race at all? I mean, in terms of does it matter from an accrediting perspective whether a person uses AI or not?
So I'm going to parse your words about does it matter, right? I think CARF would not have a opinion about whether or not AI can or should be used, right? Here's the thing that's important to understand about accreditation and about CARF specifically. So our mission statement as an organization is really focused on enhancing the quality, value, and outcomes for the person served in CARF accredited organizations. Now, there's a few more words that are in that, but everything that we're doing, the purpose and the reason why we exist, and in fact, our board of directors has established that the person served in CARF accredited organizations are the moral owners of CARF. So our purpose is to ensure that they are getting a quality service. That really our customer predominantly is organizations that are seeking accreditation, but our purpose is to reach into that organization to ensure quality for the individuals. And so the things that we're talking about that AI can offer to an organization actually is going to do those things, right? It is designed to ensure better quality, making sure things aren't falling through the cracks, making sure that the quality of that documentation is much more reflective of the experience that the person had in that particular therapy environment, right? And we've all known historically that that's been a weakness that clinicians have had. They are going from session to session to session throughout the course of a day. They're not keeping up with their notes. And then a day or 2 days or 3 days later or a week later, they're going back and writing a note, and it's probably not very reflective. It misses an awful lot of the quality of what happened in that particular session. So the fact that we can have AI that is assisting the clinician in real time to be able to keep up with those notes and to be able to have a much richer description of what happened for that person, we would view that as a win. We would view that as something that has real value. So we've never had standards that say that the person or the bulk of that note has to be formed by a sentient being. We've never had to address any of those sorts of things before. Now, clearly, it's new, and I know, we do have organizations that we accredit that are customers of Elios. So we have started to have some experience with that. I actually polled our internal staff the other day to ask, have any of you gotten any questions or comments or feedback from our survey teams on site that they had questions about this, and not a one has ever come back. So the surveyors, I think, have been able to reasonably interpret what they're seeing, make decisions, and be able to move on. And so it really, the methodology that the organization uses, the tool sets that they use to satisfy our standards, we don't prescribe. So I don't think that there is now, nor should there be in the future, any reasonable issues that could come up. Now, there's things that maybe neither of us can foresee that could happen. And, I don't know that. We have standards around, a great deal of standards around the use of telehealth, and other technologies like that. I don't know that we're going to be in the business of accrediting bots, So should there be a company that begins to sell completely humanless
bots,
autonomous bots that are providing CBT to an individual, which I could see where that could happen, right? I could see that there will be a good algorithm to be able to provide meaningful responses back to an individual that they could have value in. But I don't know that we would ever be in the business of accrediting that as a program of accreditation that would be in CARF's wheelhouse. At least in the foreseeable future.
Yeah. Well, I agree with you that there's a decent probability that could occur. We're seeing some of that with apps now. There's some EBT apps out there that they're not bots, but they have some artificial intelligence built into them, and they're autonomous. They're not, there's nobody, behind the curtain who's ringing that. But I think, I could envision a spot or a point where CARF says, if you're going to use these things, here's the expectation that you're going to manage that. Ultimately, people have to be responsible for both the notes, as Elios currently does, where it's all decision support provided to clinicians. The organization is responsible, and the clinician is responsible for that note. If you have an autonomous bot, God love you, but you're still responsible for what it does. And if it screws up, that's not the bot's fault. It's the organization.
Right. And if, let's say that if in the course of the way that care was being conceived for an individual, that perhaps, an intervention would be that an individual goes through an app or a bot-driven exercise like CBT, sort of thing, right, online. There's still a clinician that is managing that care and is still responsible for interacting with that individual and ultimately making determinations are they improving in their areas of functioning? Are they reducing symptoms in areas that they want to reduce symptoms in? Are they achieving the goals that they're seeking to achieve as a part of treatment? So, as long as someone is managing that, the interventional strategy is completely appropriate to what the individual needs, right?
I think in a way, this is not a lot different than the issue that we faced years ago as EBT started to kind of trickle into the business, that a clinician could not say, I didn't do that right because I was following this EBT protocol. You're still responsible for providing good care, whether you use a structured protocol or non-directive psychotherapy. Ultimately, a person is responsible for that, and you can't EBT was a technology of sorts that got introduced, and it kind of changed. It was a game changer, I think, for a lot of clinicians, where they had to start thinking about protocols, and on the third session, you do this and so on. But that's still, they're responsible for the outcomes and the results from that intervention. So I think that's kind of like the same problem writ small, but this is more sophisticated because you got, a semi-sentient being, being managed hopefully by a sentient being.
Yeah, for sure. And the other thing I was thinking about when you're talking too about like the use of these technologies, and which is one of the other reasons why I don't see that we would be involved in the completely touchless spaces, that we're wanting to ensure that not only is the care being delivered, but that the people who are delivering the care are trained and supervised and are evolving, right? Now, again, I can see where you can evolve an algorithm, as it gets more information, it can learn and it can begin to evolve. But it's just, I'm imagining that in the course of my lifetime working in this business, we're not going to be to that point yet where we're going to go, we're just going to be in the accreditation business of these completely autonomous bots that are providing care with no supervision and no human interaction.
Yeah. Well, I think what you've done is kind of inadvertently kind of backed into the difference between artificial intelligence and augmented intelligence. And, for every app that I know of, or every application I know of in both general healthcare and behavioral healthcare, all of them are augmented intelligence implementations that give information to a clinician to make a better decision, not make the decision for them. So I think really you kind of defined the breakpoint where if it's going to be autonomous in the way that a self-driving car is autonomous, that is artificial intelligence, but augmented intelligence gives clinicians information to make decisions. And CARF, sounds like CARF is saying, yep, that's what we're going to hold you accountable to. If you want to use that information, God love you.
Yeah. And I actually think, in terms of, and I'm not in this particular statement, I'm not saying I'm speaking to CARF. I'm just saying as somebody who has spent, 40 years working in this business, I welcome, these tools that are helping clinicians because you and I have both been in situations where we've been, running large systems of people, and it's a real challenge to be able to smooth out quality in an organization, right? You have different skill sets for individuals. If you're employing, 300 or 400 clinicians, they're not all the same in terms of their skill sets. Some people are really good in some areas and weaker in others. One of the things that I think that these tools are going to help is to level that playing field that, even if I'm not as good at recognizing a particular symptom or clusters of symptoms, this is going to help to put it in front of me. And I think about, we've been doing a lot of work, and I'm kind of working on an internal project now for the Action Alliance for Suicide Prevention, because we've made several changes to our standards trying to align things around the zero suicide framework. So I'm looking at results, what has been happening in terms of the conformance to those standards over the years that we've been making these subtle changes to the standards. And, there are a lot of individual cues that a person might present with that can be reflective of suicidal thinking that is completely missed by the clinician because it happens over 3 or 4 or 5 sessions, perhaps, but I don't know that it would get past. I'm hoping that that's the kind of value that we get, right? Is that it doesn't get past this augmented intelligence, as you say, right? That says, hey, this person has mentioned this particular thing that is risky multiple times, and maybe it's something that there needs to be some more exploration about. Now, that's going to still be left to a clinician to do, but it informs them in ways that perhaps they wouldn't have been informed because they're busy. It's the way that the system is designed, built, and the way the economic models are laid out, right? It's not the thing that we would prefer, but we have to live in the world that we live in. It's very challenging for somebody to be doing 7 or 8 hours a day of therapy, 5 days a week, 48 weeks or so a year, and be able to not miss things. And it's hard to remember that I saw you 3 weeks ago, and you were talking about X. And even if I read the note, the nuance is missed because the note has not historically been reflective of all of those things, right? And so to your point, if I've got a tool that has that history and can look back over, the last 18 sessions that we've had and be able to pull through lines of things that or themes that are constantly there that have not been resolved, I might not have noticed that. And I think that there's real value in providing that tool. I mean, as we talked about earlier, I probably was the first person in this country who was doing significant EMR implementations because, CMHC Systems, was who I worked for. They were the first to come to market with an EMR. I was their EMR implementation person. And so one of the things that we were talking about was, well, this is going to make things better. Well, it really didn't. To your point earlier, that the current tools are actually the first thing that are actually driving something better. For the most part, all we did was we took paper and digitized it,
right,
We didn't add any value. We didn't add any smarts. It was just filling out forms on the computer as opposed to filling it out on paper. And that's the way that most of the EMRs have worked. And it actually has created more stress and tension, I think, for clinicians. And so I do agree that what is being brought to market today is the first time that it's actually helping me to do my job better, and a tool that is designed to ensure that things are not escaping my attention. And it's even helping to shape, in the session that I delivered today that was supposed to be using EMDR or CBT, informing me about how I did, giving me a scorecard, if you will, about whether or not I had fidelity to that evidence-based practice. So that actually is passively improving supervision, if you will. So these really we're finally, years and years later, getting to a place where there are tools that are designed to enhance the quality of the service, not just documenting that the service happened the way that it always was.
We might want to consider giving an award to any of the listeners who know what CMHC systems was.
Yeah. Well, back in the old times.
But just for the audience that don't know, it was one of the first, maybe the first behavioral health EMR company that ultimately, through merger and other things, became NetSmart. And so, the one thing, and I agree with you, was kind of my point earlier, that they did not. We said it would add value, it makes your life easier. It never was, not quite the opposite. So we're kind of running out of time here. I wanted to kind of land on kind of as a summary. What would you want our listeners to know about CARF in general, and specifically about kind of CARF's view of the role of AI in behavioral health? Well,
about CARF specifically, I think, you and I had a conversation about what are what's kind of the things that people misinterpret about accreditation, or that they don't really understand about it. And, I think a lot of people think about accreditation as the survey and the certificate on the wall. And I'm not saying that those things aren't important, but that's not what accreditation is. Accreditation is an internal quality improvement activity that's a systematic one, that's based on a set of standards that are field tested and that are kind of the best practices for the field. But the work that an organization goes through is what's important. And as organizations are examining what are the things that we're doing that are enhancing quality, that is designed to improve outcomes, that is designed to ensure the best quality of services to the individuals that are being served, executive leaders in these organizations should be looking at the tools that are available to them to ensure that they're able to deliver to their clinicians the tools that they need in order to ensure, to the best of their ability, those outcomes for the individuals that they're providing care to. So it's incumbent upon organizations to look at, what can I acquire to ensure, that I'm delivering this, and the data that you can then get around fidelity to evidence-based practices, ensuring the timeliness of notes, ensuring the quality of those notes. Those are all things that are, it's not about the note itself. It's that's just another tool that is in the hands of the clinician that is designed to drive greater focus, greater fidelity to their own individual treatment plan over time. And so for me, as as somebody who has spent my entire adult life in the behavioral health space, it's really important that we begin to seek parity, with the rest of the healthcare system, and to ensure that we are, not just providing care off the backs of the clinicians, but actually supporting them in delivering the best possible care that is going to result in the highest quality of services to individuals that seek us out for their needs to improve the quality of their life. So
excellent. Thank you so much. Always a pleasure. I think we could have gone another hour or so on this, especially getting into those things where we could go with AI, but that's going to wrap it up for us today. Michael, thank you again. And always good seeing you. And we are out.